Good morning. My name is Baikong Kauting, your nurse liaison officer from Director of Nursing. Welcome everyone to Cardiothoracic ICU. And today I'm gonna give you a topic about the handover and immediate responsibilities. This is helpful to every one of us to set the standard for the safe practice. So by the end of this session, you will gonna be able to identify the components of structured ISBAR, describe timely why handover post-actions are essential, demonstrate steps to check the equipment, lines, and infusions that the patient's got, assess the findings and prioritize clinical actions, and lastly, reflect on safe handover and early shift practice. In ICU, we are using the ISBAR format as a form of a structured handover. So this ISBAR has its own acronyms. I means identification, which is we have to identify the patient's name, the age, procedures, and how many days a patient already in ICU. S stands for situation, which it says that the patient's current status, reason for admission, and so on. So for the B stands for patient's background. So background, which means surgical details, comorbidities the patient has. For the A stands for assessments. Assessments may fall where your vital signs may fall, sedations, ventilations, lines, and patient's drains. The R means recommendation. Recommendation means the pending tasks, the blood investigations that the doctors order, and if there is any procedures that are still pending for the patient. So now we're gonna go to our next topic, which is importance of early actions. So early actions got the three process. First is the confirming of the stability of the patients, prevent complications, and also detect the deterioration early. So first one is confirm stability. You need to verify that the patient is currently stable based on our objective data. Why? Because in cardiothoracic ICU, every second counts. After handover, your patient just transition from one set eyes to yours. And you are now the safety net. This first half hour is not just a routine. It's your golden window, a golden window to act before the small issues become the big ones. So this includes checking the vital signs, comparing them to what we have in our baseline, and reviewing the ventilator settings, oxygenation if the patient's got, what is the oxygenation status like ABGs, and then making sure of what patients got sedation, and also inotropic supports, infusions that are running. So these are all essentials as a part of handover. The next is preventing any complications. Early checks catch things before they cause harms. So you're looking now for if there is any dislodged lines, unsecured APTs, if ever there are kink drains, or incorrectly programmed infusion pumps, or any missing or faulty emergency equipments. So number 3 is the detect the deterioration early. Subtle signs can indicate a downward trend where your clinical judgment begins to sharpen. So now we must watch for increasing vasopressor requirements, rising lactate levels, diminished urine outputs, and also mental status changes. For all these things, we must be an update of our patients, and we must inform our doctor. So now we will go to immediate actions post handover. The first thing that we have to do after handover is to introduce ourselves to our patients. When the patient is awake, they will really understand us, see us, and also on. So we must also reassure them and establish rapport. So even guys, remember that even patient is sedated, they can even hear us. So remember to even introduce ourselves also even to our patients sedated and ventilated. The next one is the safety equipments. So for the safety equipments, we must confirm our patient's oxygen support if it is connected and functioning. We have to check also if our suctioning is working and available to our bedside. Ambu bag is already checked and available. We must also check that thing. And then if there is a new set of medications, like for our inotropic supports as a backup one, and also the sedations if ever needed. Yeah. And the third one is for the inspection of lines and drains. So we have to, from the port itself, we must trace all those medication from the central venous line to make sure that it is in the correct line. So we must ensure its patency and also the securement of our invasive lines. So for the wounds, we must check from the wound itself towards the drains, and then we have to check if the drains is not bleeding actively, if it is just moderate and small amount, and what type of drain patient got. And then also if patient is having ECMO, you have to check also the settings of the ECMO that the doctors order, if there are any changes. Then for the CRRT, we must also check what is the doctor's order, and we have to compare it with our present one. So if patient got a BA catheters, we must also review the trends. For the arterial line, CBP, CCO, and also IABP, we must also zero all those devices, and also we have to check if it is properly labeled. We are now in setting the priorities. So there are 3 questions that we must bear in mind for this. First is, what's my main concern for this patient right now, right after handover? So this is your central clinical questions actually that you must focus or you must bear in mind. Because really, this one is really focuses to review all the findings holistically and identify the most urgent or abnormal issues. Like, for example, you receive the patients and you notice that a while ago patient is having a sinus rhythm and now the patient is having sinus tachycardia. So there is already a variation from your baseline. So you must further assess the patient. Maybe the patient is having a fever or is just having or needing another sedation if patient is sedated, or might be the patient is in pain. Another question here is, which interventions are needed urgently? So the next question really talks about our prioritization. This is based on our concerns. We must decide what we have or what we need to do. This is about immediately versus what can wait. So, third question that we must bear in mind is are there any signs of deterioration or instability for these patients? So here we must look for any clues of a bigger problem. This might not be a full-blown emergencies yet, but they are warning lights for us. So for example, the urine of the patient is less than 0.5 kg, 0.5 ml per kg per hour. So actually in our mind, this really indicates a poor renal perfusion. So it can be an indication of hypovolemia, low cardiac output, or sometimes renal failure. So as a nurse, what is our intervention? ICU nurses. So our intervention, like checking of the mean arterial pressure of the patient, fluid balance, and assess for the need of interventions. Maybe your Foley catheter is just kink, or like further assessment is needed. We are in the reflect and communicate. My dear colleagues, escalation is not a weakness, actually it's a strength. Communicate respectfully but urgently, and work collaboratively, not in isolation. Wrap up with our topic for today. I just want to remind you that please follow a structured process. Be methodological. Never hesitate to clarify or escalate. You are the eyes and the ears and also the hands of this unit. With what you do in those first 30 minutes can make all the difference. Welcome to Cardiothoracic ICU, where the excellence begins at the handover. Good luck and thank you so much.